Thank you, Marie-France, for Deloitte and Pharma for bringing us together to talk about sustainability. And it would be wonderful if we could maybe get straight into it and simply ask you the question, what does sustainability mean to you personally and to Novartis?
So clearly, sustainability is when something is fit to serve or support whatever it is in the present and the future. And, I'm sure you're going to ask me about the healthcare system and its sustainability. And clearly, I don't think that it's very fit. It's not very sustainable. And there are many reasons. And I think those reasons are just becoming more and more present as we interact and work in this ecosystem. You have things like healthcare costs that are exploding. You have massive waste in the system. And, US has like $850 billion of waste a year just in how patients or the system interacts. So it's a huge amount of cost. You have aging populations. You have an evolution in what patients are looking for. So clearly in my book, we have an issue with sustainability in the healthcare system.
But what then needs to change in the healthcare system? Because it's, one company, one agent can't change it all. So what is it that needs to change in the healthcare system, and who or what needs to change? It takes two to tango.
Well, it takes probably more than two to tango, and you're absolutely right. I think, our industry is just very fragmented, and I don't think that's going to change anytime soon. But I think that we have to kind of almost take a step back and think about the agenda, right? What is the healthcare agenda? And today, when you look at the entire system, it is entirely built around intervention. You go to the healthcare system when you're sick. The incentives for physicians are to treat or to operate or to do surgeries. And we where we can, it's not possible everywhere, but where we can, why don't we start to think about prevention? So prevention instead of intervention. And when you start to think like that, you look at diseases such as, many in the cardiovascular space. Actually, 80% of the deaths that we're seeing are preventable in CVD. So why don't we take that approach? That's definitely going to take waste out of the system, create more sustainability, more productivity. So that's the first thing, prevention versus intervention. The second thing is, I really think we need to take a look at health inequities. So, even in the developed world, right? If you take a city like Philadelphia, within a very short space, like a couple of miles, you see a life expectancy difference of 10 years. 10 years in the same city means that no matter what you do, you've got to address the underserved population in the developed and obviously in the underdeveloped world. So that is something that we really have to kind of take on. And the third thing is, I do think that there's room for much more private-public partnerships. And we've actually seen that with COVID. That's a fantastic example of people just coming together, gearing around one objective, and then saying, let's solve this, and let's solve it as quickly as possible. So it can be done.
Yeah, and COVID was really a good example of how stakeholders in the ecosystem can come together. But in this new approach to sort of thinking about sustainable healthcare, whose responsibility is health then? Is it the individuals? Is it the doctors? Is it the companies? Whose responsibility does health become in this sort of shifting sands of sustainability?
So I think it's a really interesting question. I think it's everybody's responsibility. It's our responsibility to take care of ourselves, but it is also everyone's responsibility to shape the healthcare agenda, to determine what the priorities are, to determine where the investments go, and then to get the medicines that are actually there that can support patients to the patients that need them. So, it's interesting, but I often look at our objectives around climate change and what we want to do for carbon emissions. We don't really have the same objectives in healthcare, but we should, especially where we can. Why don't we have objectives that talk about we're going to reduce cardiovascular risk or deaths in our country by 50% by 2030? It's totally doable, but we just don't talk about it. So to answer your question, everyone has a role to play. We've got to sit down, align on the agenda, align on the incentives, and then implement.
I love what you say, because there have been precedents, whether that's sort of tuberculosis or syphilis, where we had those moves in the past, but we've also had it with emphasis on COVID, but we've also had it with Hep C. But it then raises the question, how does a company like Novartis begin to think about changing its portfolio, its products and services, and even the timeline with which you think these have impacted? How do you think about those changes within your company?
Yeah, look, I think we need to just take a very much broader view, right? Mm-hmm. So traditionally, our industry has been very focused on the science, which shouldn't change. We have to continue to focus on the science. But then we focused so much on products. These are the product characteristics of our drug. This is what it can bring. This is the value. And then we have a very transactional relationship with society, and that can change. We have incredibly talented people who are super committed to the purpose of helping change the face of human health. I think we need to just interact differently with systems, sit down with systems of care, understand what their priorities are, take a much more customer-focused lens on what actually needs to happen. What are patients struggling with? What are physicians struggling with? What are the healthcare systems struggling with? And if we get forensic about that, you can actually start to change that. You can actually start to understand, why is it that patients don't stay on their therapy? Why is it in the US that 1 out of 3 prescriptions is actually getting filled? You can really focus in on what's the problem to solve, and then who are the actors that I need to bring together to try and solve that problem.
So are you effectively building a sort of sustainability by design, by Novartis approach to working with healthcare systems and choosing your new products and treatments?
I don't think we have a choice. I mean, I think I love the title, Sustainability by Design. I think that's really, really a nice way of putting it. But I don't think we have a choice. I think we will have to work differently. And I do think that at some point society is going to ask us to take accountability for the outcomes. We have a great drug. We know what it can deliver. Now, let's see that happen in the healthcare system. For that, we also need the healthcare ecosystem to have skin in the game, to also take accountability. So how do we work together to determine what the healthcare pathways are? How do we, with the system, support bringing patients in so that they can be treated? And then, absolutely, we should be accountable for, are we actually delivering what we promised this drug could deliver?
But how do you then compete in an environment with other pharmaceutical firms and maybe even with other stakeholders? I mean, I think in this sort of world of sustainability and the way we've just defined it, actually who you compete with, who you need to collaborate with is actually changing. But how do you make a mark and how do you become unique in that world?
I think it's just establishing trust. It's establishing trust with the system and the stakeholders that you're working with. And I think there's so much, unfortunately, so much disease out there. There's so many patients that today are unattended. It's actually not what the issue is. It's not our competitors. The competitors for us are actually the barriers in the system. Mm-hmm. So if we all work together to start to remove some of those barriers, make it easier, whatever it is, whether it's access, it's affordability, it's adherence, all of these challenges that are in the system itself, start to pull those away, there's enough room for everyone.
That's interesting. But do you therefore see, will we move into a world, hypothetically speaking, where one company owns a pathway with products and solutions? I mean, are we seeing a world where it is almost a tremendous focus around covering that whole spectrum and there's no real room for anyone else? Or do you see that actually being room for multiple players, even within one disease like cardiovascular?
It has to be, because patients don't have one disease normally, right? Or they don't have one disease throughout their entire lifetime. So it's very difficult for one company that has a spectacular drug in a particular area to sit alone. And that's okay. We should be looking at the whole disease state. And if that means that, as industry, we need to come together and work on those pathways, then we should.
But do you therefore see then also completely different payment and reward models of how the cost and the outcomes really get shared? Because today we're in this sort of in-year, immediate results type model. But what you're describing is almost a population health where the extreme could be that a country pays a company a certain amount a year and says, we want all your products and all your services for that disease. Could you imagine those types of models?
I think we've been much further away from that than we are today. I think that is absolutely on the horizon, and it's a good thing. I think that you know that we're very interested in new commercial models and partnerships and thinking differently, with the basic idea of getting broader access faster. I mean, that is a key, let's say, strategic value driver for us is, can we think about broader access faster? And what needs to happen for us to do that on all levels? Whether we're talking about the affordability of a medicine, whether we're talking about making sure that those access pathways are defined. And then, yes, we have to think about innovative models for that sustainability to be durable over time.
Yeah, and I think what you're describing for me is also a move away from individually high-priced drugs to actually thinking about what are the outcomes for population over time. But then, if we've talked about this as a destination almost, the transition is not straightforward. Mm-hmm. And I suppose you already have been experimenting with those types of outcomes deals in the US and in the UK, just to name a few examples. What are the lessons from running a sort of population outcomes-based model as well as on a payment by volume almost model simultaneously? Well, what are your lessons out of that?
The first thing I'd say is that it's hard.
Mm-hmm.
It's not easy, and it takes very different skills and capabilities than what we've traditionally had. So we need to hire population health specialists. We need to hire people who have a lot of experience in looking at data in digital, digital understanding of what can actually be done. We need to basically think about public affairs in a different way. So, and then you interact with systems that very often are incredibly complex, that have incentives that are completely disaligned, that are honestly much more complex than even a big pharma company like Novartis. So going in there and trying to find the right people who can help have the right conversations, it's an effort, and it's new to us, but it's fascinating. And my conclusion is it's absolutely worth it, because at the end of the day, you do get people who say, this is exactly what we're trying to do. So that's our approach. We're trying to be much more centered on how do we help our customers resolve their problems. And ultimately, you can actually boil it down to very, very similar objectives that serve society. And that's where we're headed.
But you mentioned the capabilities required. It's a really interesting comment. What are the capabilities that are different in this new world? What type of skills do people need to have? Is it about vision? Is it about technical capability? Is it about population health? Is it actuarial? What are the type of capabilities?
I think, so from an organizational perspective, it's really moving away from the focus solely on the product to what many other industries have done, which is focus on my customer needs. And so the requirement there is, first of all, you need to support all of that with data to really understand your customer, because that's not coming from within, that's coming from your customer. So a lot of data management, data analytics, digital enablement of certain processes, the agility. You need a lot more agility than we had in the past. Society's changing. People want things in real time when it matters to them. The personalization of engagement with healthcare professionals. I mean, we used to have new materials every three to 4 months, and now we need to be there 24/7 at the time and the moment where it matters. And so that requires a huge change from our own data informatics, and our own systems need to change fundamentally. So certainly we're working towards that as well. And then it's the type of engagement that you have with physicians and systems. Right now, there's a huge focus on implementation science. Mm-hmm. You have a product, you have a drug, you have the guidelines. How do you make sure that it gets implemented through the system? How do you get the quality improvement that is necessary for those outcomes to be realized? And those are the types of new skills and capabilities that we need to build within our own industry.
Yeah, I mean, those are challenging skills to build. And, I think also on the other side requires education and the skills to be built on their side as well. But are you, as we are moving towards that vision, are there countries which are already there or which are easier to deal with, where one can really try that new model?
Certainly there are countries that are easier than others, right? Where we will see more of an open door policy. And, we're working with the launch of our new cardiovascular medicine. We're working with 200 systems of care in the US. And obviously some systems are more willing than others and see that as an opportunity versus something that is maybe nice to have. So I do think that on every level, it still depends on people, right? It depends on people and how. So that's why we have to continue to interact with the healthcare ecosystem. That is important, and find those areas of joint objectives or where joint accountability makes sense.
Well, that's very logical and very clear. And we talked a lot about the customer needs and reacting to those, but I wonder, what is the impact on investors, on talent? Do you notice a difference already, that they are either on board, that they're talent? Is that a way of recruiting people, investors? Is that a palatable story? Because the economics become different, at least, maybe not more uncertain, but at least different.
So, I've been hearing for at least a decade, why are we still working with pharmaceutical sales representatives, right? So people have been questioning them. It's more than a decade, actually. It's probably since I was a pharma rep. And let me be clear, I do think that face-to-face contact is really important, and that certainly isn't going to change, at least in my lifetime. I think that so much happens when you're face-to-face with someone, and you can have that conversation versus being in a virtual environment. But I do think our model needs to change. Mm-hmm. And I do think that when you look at all of the things that we talked about in the beginning of our conversation, what patients expect, the aging population, chronic diseases going up, the overwhelming amount of information that hits a healthcare professional, we have to change the way we work. We have to adapt. We have to be much more agile. We have to be much more in the moment, and we have to be much more personalized in what we're delivering. And today, I just don't think that we're providing that service to the ecosystem. So that's what needs to change.
So what, if you wind forward maybe 10, 15 years or even 20 years, what does good look like? What is the company that is Novartis then, and what is the relationship with the healthcare system that you could imagine as a reality?
I'll go back to what I said before. I think we will have a system that is much more proactive and focused on prevention where it can be possible. And that is clearly the case in many disease areas, starting with atherosclerotic cardiovascular disease, with diabetes, and looking forward, it may be even with Alzheimer's. So these are areas that we can think about very differently. The second aspect is that we will have addressed the inequities in the system, or at least tried to become much more holistic and broad about the way we're thinking about human health. Mm-hmm. And then the third objective for me would be that public-private partnership is not questioned anymore. It's just a given that we're going to work together to work on what needs to be done. What's the job to be done? What do we need to solve for? If we do that, I think we'll go a long way in improving human health.
Yeah, we talked a lot about how sustainability can really reimagine medicine and how we treat people. But is this universally applicable to all diseases, or are there particular diseases where you say, actually, that's where we need to start, that's where the golden opportunity is?
My belief is that we have to start where it matters, where it's big. And it doesn't mean that the other diseases don't matter, but there's so much opportunity in addressing the bigger diseases, the ones that are just affecting so many millions of lives. Look at cardiovascular disease. 300 million people worldwide are affected by cardiovascular disease. So obviously, it's a big, big item for the healthcare system worldwide. And that's diseases such as CVD is just a logical place to start because it affects such a broad population. not every single disease area is going to be, let's say, prone to these types of engagements or arrangements. But I do think that we would address a big chunk, and that would support then reinvesting healthcare dollars into other disease areas that are perhaps less preventable.
And it's a wonderful comment, because I think clearly the last few years have seen a trend for more medicines being targeted at ever smaller populations and diseases with very high unmet needs, mainly because there has been some solutions for cardiovascular diabetes, but it doesn't mean that there's no unmet. That's where the public health, the social health benefit is.
And actually those diseases are now on the rise. So if you look at the mortality from cardiovascular, where we made tremendous progress during decades, that mortality is going back up. So something needs to be done.
And the way of thinking about that through prevention as well, I think, is a real where the game changer is, to move those diseases away from this focus on treatment, of acute treatment, to prevention, including maybe even behavioral aspects of it.
Yeah, really, I mean, powerful. 18 million deaths, right? 18 million deaths a year. That's actually more than all oncology deaths combined. And 80% of it is preventable. 80%. So we should be talking about this differently.
And that will make a difference. And I hope we get there by the time I really need it. Thank you very much.